Wonderful. We're going to go ahead and get started. This is the monthly Psychedelic Support speaker series, and I'm Dr. Allison Feduccia, the co-founder of Psychedelic Support, and I'm a neuropharmacologist and very excited about this topic of psychedelics for women's health. Typically, I host this monthly speaker series, but today I'm going to be doing both hosting and presenting. We always encourage you to drop in the chat your name, where you're calling from. It's a great place to network and communicate. And if you have additional resources, please do put them into the chat here. I typically will be dropping links, but I have a document prepared today that I will share at the end with all the links from the course. Actually, I can try to do it right now, but I'm going to have to unshare my screen for a sec to get it, I think. Well, actually, maybe I can get it. Okay, yeah, here's the references for you with links out to what I'll be talking about today. Okay, so, my interest in this topic is both personal and professional. The first lab I ever worked in at the University of Texas was an endocrinology lab. And there we were studying how environmental toxins can disrupt female reproductive systems. And just a note before we dive in, I will be using the words female and women throughout the course. But as we know, it's helpful for men in our lives to better understand females, and this is also inclusive of transgender men who may be menstruating or non-binary or transgender people. So this is all inclusive, and we're going to be reviewing lots of literature, and let's get going here. All right. There we go. Okay, so the outline for today is we're going to start off by talking about why study women in the first place. We're going to do a refresher on how neurochemicals and hormones interact in the brain and the body. We'll take a look at the life cycle of females, how indigenous plant medicine traditions have used psychoactive substance for women's health. We'll move on to understand how anecdotal reports from women are starting to drive some of the research and gives us a great place for hypothesizing neurobiological mechanisms of psychedelics and potential applications for women's health. We'll talk briefly about the psychedelic therapy for mental health and wrap up with where is this all heading? If you have questions along the way, you can drop them into the QA box down there at the bottom of your screen. I'm going to try to get to as many questions as we can at the end. And even if we go over a little bit on time today, it's typically an hour, I'm going to stay on and get to some questions. Okay, so why study women in the first place? Well, women make up 50% of the population. However, the majority of preclinical research, which includes all the experimentation before drugs typically make it to humans, are done in rodent models. And looking at a 100-year period from 1909 to 2009, it was shown that only 15% of these studies included both sexes. So these sex differences between males and females are very important for how our brains and our bodies function, and additionally, how we might respond to different medications. In fact, it's known that drug side effects can be more frequent and more severe in women. And from 1997 to 2000, 8 out of 10 drugs that were pulled from the market by the FDA caused greater health risk in women. So let's review the menstrual cycle. So it starts with menstruation. Typically, it lasts 3 to 7 days for women. The next phase is the follicular phase. Actually starts on day 1 of the cycle. But during this phase, we're seeing the follicles start to form within the ovaries. We're starting also to see, if we look on the left side here, estradiol is rising during the follicular phase. The dotted line represents ovulation, which typically lasts 24 to 48 hours. At this point, estrogen is at its peak, and it triggers the release of a mature egg. But right after that release, we see a sharp decline of estrogen and progesterone starts to rise in the body. During this phase, called the luteal phase, which is after ovulation until the next period happens. So it's this tango between estrogen and progesterone that happens across the cycle. And these fluctuations in hormones are known to produce some profound effects on the brain and how we think and feel. So it can actually impact the structure and function in our brain. It can alter neurochemistry, meaning how the neurons are signaling between each other, can modulate emotion and cognition, and fluctuating hormones have a big role in our risk for developing anxiety and depression. Okay, so let's take a closer look at this idea of, we know this is a natural process where we have these fluctuations of hormones across the cycle, but females also have a higher prevalence of most psychiatric disorders. Something on the order of 2 times the rate as men for depression and anxiety, PTSD, eating disorders, and other stress-related conditions are all much higher prevalence. Women are also at a heightened risk for psychiatric disorders during the reproductive years and at transitional points across the life cycle, which we're going to talk more about in the next slides. There's also strong evidence to support that hormone fluctuations are a major driver of the sex differences in this risk factor for psychiatric symptoms or disorders. But also want to draw some attention to the environmental impacts. And we know that women are more likely to experience traumatic events throughout their life. Socioeconomic factors can play a role. Men and women don't make the same pay rates. The pay gap is estimated to be about 22 to 30% here in the US between males and females, and this has been static for the past 20 years. Women also report greater stress related to balancing work-life balance, perhaps more demands in raising up kids or managing the household. And women also feel greater stress around their physical appearance and body image. There's systemic discrimination that can occur too, and all of this may play in as well to environmental factors that can heighten risk for people developing psychiatric conditions. Another point to keep in mind is that men and women can have different profiles around addiction disorders, and that often men, it's been found, will seek out substance use for more risky behavior, for more pleasure, whereas women actually are more likely to self-medicate with drugs or alcohol to reduce stress or anxiety. And the patterns of how people kind of get into a slippery slope with transitioning from using a substance to it being a problem in their life looks much different between men and women. And women are also more vulnerable to the stress-induced relapse of addiction disorders. Okay, so let's take a closer look at how hormone fluctuations can impact the risk for depression. It's a really elegant study here that we're going to go over this graph. So we see that before reproductive years, before puberty, men and, well, I guess we call them males and females, have about the same rate of depression and the risk for developing depression. But once we hit puberty, we see this differentiation between males and females, and that women have a much higher risk of depression during these reproductive years. The top part of the graph is showing that risk of depression, and the lower part of the graph is showing the cyclical fluctuations of hormones of estrogen and progesterone primarily that we just saw in the previous slides. So this erratic role of hormone fluctuations really starts to happen when a person reaches the age, usually in their 40s, of the phase of menopause, which actually includes 3 parts: perimenopause, which are the years before someone actually stops ovulating. And during this period of time, it can typically last on average 4 years, anywhere from 2 to 8 years is normal. And At the time, we're seeing on the bottom graph here that the ovarian hormones just kind of get crazy, sideways, up, down, and less predictable with this monthly cycle. And menopause is actually marked by the date where someone has not had a period for 12 months. And then during postmenopause, we see a drop off of these circulating hormones. And the thing to note here is during perimenopause, we see another spike in the risk of women developing depression, whereas men just sort of stay the same. And then after menopause, that risk goes down. So it's a very close tracking between fluctuating hormones and our risk for depression. And at this time too, I just want to mention this concept of estrogen withdrawal. We'll talk more about this as a possible mechanism of why people start to experience symptoms related to menopause. Okay, so let's do a quick refresher of the endocrine system. And by understanding the complexity of these systems, we can get a better sense of where things could possibly go wrong and potential interventions. So the endocrine system refers to all the glands and organs throughout the body that release hormones into your bloodstream. It includes the reproductive organs, testes in men, ovaries in women. It also includes the placenta during pregnancy. Includes the hypothalamus, which is found in your brain, the pineal gland, pituitary gland, the thyroid glands, parathyroid glands, thymus, your adrenal glands, which sit like little hats on top of your kidneys, and the pancreas. So the hypothalamic pituitary gonadal axis is a very important system for regulating the flow of hormones in our body. And you can see here on the graph that it's a two-way street between the brain and the body. So the hypothalamus is producing several signaling molecules that will stimulate from the reproductive organs to release the sex hormones we've been talking about, estrogen, progesterone in women, and testosterone in men. These can have a circulating back negative feedback loop to the brain to say, hey, there's enough in the body, turn it off, or perhaps to increase that release of different types of hormones. So it's a complicated system where a lot of things could potentially go wrong or have different medications or interventions intervene there. And also just to note, women do have small amounts of testosterone and other hormones circulating through their body, but this is a little bit just simplified for our discussion here. Another really important system to think about is the hypothalamic pituitary adrenal axis. In a similar way, it's the brain is communicating to other organs in the body, including the adrenal glands, to release cortisol. We all know how important cortisol is for normal function, but when chronically elevated in the cases of stress, it can wreak havoc on the body. So these systems all work together. And another important one is the gut microbiome, which includes trillions of microorganisms, including bacteria, viruses, and fungi. And also in the gut is a very substantial amount of serotonin. Actually, 95% is produced in our gut and only 5% in our brain. And it's also been found that this microbiota is a key regulator of circulating estrogen. And it does this by secreting an enzyme called beta-glucuronidase, which makes estrogen into its active forms. And so there's some studies that have shown when there's low microbiota diversity, we have reduced circulating levels of estrogen. And this low microbiota diversity has been linked to many different diseases. And so there's many ways that they're finding that the gut actually communicates to the brain and the brain communicates to the gut, either through signaling molecules or, as we just discussed, modulating different types of hormone levels. And then there's also the enteric nervous system, which is part of the gut's way of communicating to the brain and vice versa. So we know too that there is a substantial interaction of sex hormones in the brain, not just in the hypothalamus, but in other brain regions as well. So for example, we see that estrogen can affect pretty much every neurotransmitter system in the brain, serotonergic, noradrenergic, GABAergic, dopaminergic, and glutamatergic. All of these systems are heavily involved in mood, emotion, reward processing, cognition, and other brain functions. Estrogen can actually increase the synthesis of serotonin, and it can also enhance the release across neurons of serotonin. And it can also have acts to enhance, suppress, or have dual effects, which is fascinating in and of itself. It does a lot of things to the brain. Okay, so moved on to look at the life cycle of females. So we see some significant milestones or transition points across the life cycle where women may be at greater risk for experiencing negative symptoms or developing physical or mental health conditions. So we've already discussed how fluctuating hormones can play a role, but during these transition points, we're also more vulnerable for psychological impacts, and we may be facing some significant life changes during these periods of life. And so we're going to talk more about each one of these. And of course, women can be affected by many more conditions and things that are very specific, but we're going to go through the ones here that are probably the most common. Premenstrual syndrome, PMS, this affects 47.8% of people when a sample was pulled worldwide looking at women. There's also been estimates that it's more like 75% of women in reproductive age will experience some symptoms, with more than 100 symptoms being reported, both physical and mental. So common symptoms you're probably familiar with: mood swings, depression, irritability, abdominal cramps, headache, generalized pain, abdominal bloating, breast swelling and tenderness, and appetite changes. Premenstrual dysphoric disorder affects about 3 to 8% of women, and this is where symptoms are more extreme. It's classified as a DSM-5 depressive disorder. And here, PMS symptoms can be exacerbated, but what's really defining about this condition is that there's a really severe impact on symptoms of anxiety, depression, and mood changes. Typical treatments include SSRIs and hormonal birth control, as well as some lifestyle changes like stress management, dietary changes, and exercise can be helpful. And one thing to note about PMDD is there isn't a difference in the circulating hormones of progesterone and estrogen, but it does seem like people are more sensitive to the changes in these fluctuations and possibly their modulation of neurotransmitters such as serotonin and GABA. Okay, when people reach the age where they want to start having children, sometimes there are fertility issues, which include for women under 30, about 13% of the population. When a woman reaches the age of 30 to 39, that jumps to 22% and goes even higher for women in their 40s. There are some lifestyle factors that can affect this, such as smoking, alcohol, weight fluctuations, and stress. And you may notice stress seems to be coming up quite a bit across all of these different conditions. Sexual dysfunctions affects 43% of women and only 31% of men. And this can be associated with several different types of medical or psychological causes. We know that women often experience trauma and sexual abuse at a higher rate than men, and can potentially have more difficulty in the bedroom with some challenges there. Postpartum depression affects 10 to 20% of mothers, and this wasn't really widely recognized until the 1980s. Can be sort of stigmatizing and becoming more known about how this can affect people. The idea of baby blues is quite common. For new mothers, this is a big life change for both parents. Fathers can also suffer from PPD. But you can imagine having a new baby at home. There's a lack of sleep. There's worry about if they're being cared for. But but what can happen is that the symptoms can become more severe. So really severe depression, uncontrollable crying, difficulty bonding with the baby, withdrawal from family and friends, significant sleep issues, and appetite changes. So all of this can have negative impacts on both the baby and the mother. And there are some treatments that we'll talk about, but I see this as being a really interesting area to focus on with psychedelic medicines. Another area of time of life is this phase of menopause. So during perimenopause, 85% of women will have some symptoms such as hot flashes, night sweats, insomnia, vaginal dryness, mood disorders, and weight gain. The treatments for this include hormone therapy, antidepressants, gabapentin, and clonidine, which may help some people with hot flashes, and again, lifestyle modifications. So the end of life, or if someone's facing a life-threatening illness, we know our medical system is really great at addressing their physical needs and treating an illness or disease. But we see the system sort of fall short on helping people address the psychological challenges that come with this phase of life or a life-threatening illness. And we see a lot of the same symptoms increase, also a sense of hopelessness. We don't have great support for helping people navigate death themselves or with their family. And they may start to lack meaning and purpose at the end of life, and this can lead to decreased quality of life and social interactions. Okay, so turning on to psychedelics and how they may be able to help women across the life cycle with some of these psychological and physical issues. But to address this question, we need to better characterize what we mean by this word psychedelics, because it's a catch-all for a number of different compounds that have distinct pharmacology. So classic psychedelics, which include psilocybin, LSD, DMT, and mescaline, they have a primary activity at the serotonin type 2 receptor. They also hit a number of other receptors in the body. Entactogens, the most well-known is MDMA, also known as ecstasy. This one works by binding to proteins that would normally be taking neurotransmitters back into the neurons, but they're very tricky in that it can bind to the SERT-NET or DAT to release serotonin, norepinephrine, and dopamine into the synapse, where they can go on to activate other receptors and cause the release of hormones, including DHEA, ACTH, which you'll remember back in the other slides is related to cortisol, but also DHEA is related to modulating sex hormones. Oxytocin is one you may be familiar with MDMA, but it also stimulates the release of prolactin, vasopressin, and cortisol. Another drug class is the dissociatives. Ketamine is the one you're probably most familiar from this drug class. It also has a complex pharmacology, but it's most known as being an NMDA receptor antagonist. So all of this is to say that it's a pretty messy pharmacology, and that they each have distinct subjective experiences, and they also have their own unique safety profile to be aware of, with different risks for side effects across these different drug classes. Okay, so why psychedelics? How might they be helpful for women's health issues? We can think about this in a few different ways, but the psychological and neurobiological effects could likely be playing into potential treatments. What's been most studied is the psychological and mental aspects of psychedelic assisted therapy, where somebody will take a psychedelic substance first by doing preparation and integration sessions, often with a therapist or a guide, and then taking a full dose session to really look at different aspects of their life, their challenges, maybe gaining perspective about some of the struggles that they're facing. Another interesting point to think about the potential for psychedelics is when we experience pain or low mood, that may be present in us and we may feel that, but, it's our response and how much it bothers us. This is an interesting intervention to say for people that have pain, it may still be there, and some medications work this way of just reducing not the actual physical signal from the pain to the brain, but to say how much we reduce the psychological aspects of it bothering and interfering with my life. Possible neurobiological interventions could be through modulation of hormones or neurotransmitters. And this is where it gets really interesting, and where the research hasn't gone yet is the question of whether or not we could use psychedelic substances to tune these different systems, and maybe at different points in the endocrine system of regulating hormones and neurotransmitters, and ultimately the symptoms that people feel. Another possible application is, could they be used for prevention or well-being before you actually reach the disease state or place where you're experiencing increased psychiatric symptoms? Another attractive thing about psychedelics is typically the full dose sessions are spaced at least a month apart, unlike traditional medications where you're prescribed a daily dose to take every day. The side effects for some of the common prescriptions we discussed already, such as SSRIs, can have negative impacts, side effects such as weight gain. It can decrease sexual function. All of these things, side effects are a natural part of any type of drug, including psychedelics, but because you're only taking it intermittently, the side effects may not be as long lasting. This also gives some advantages for breastfeeding mothers that don't want to expose their baby to medications, which we'll talk a little bit more in the next slides. And it's possibly that we could use a psychedelic substance only at certain points in time in the menstrual cycle as a way of preventing symptoms before they actually happened. Or perhaps when you start to feel them come on, there could be an intervention given at that point. Okay, so what do we know about using psychedelics for women's health issues? So there are some really interesting anthropological reports from traditional cultures that use psychoactive plant medicines, including mescaline, ayahuasca, and psilocybin. In Mexico and South America is where some of these reports have come up. And in the resource doc I gave you, I did link off to some publications that go into more depth about these observations in these cultures. But first and foremost, the use of plant medicines is highly embedded in every aspect of rituals and ceremonies. And so it's no surprise that if someone was undergoing a difficult birth or unable to, say, produce milk, that turning to their plant teachers, their sacred sacraments for strength and connection to spirit, to carry a prayer of hope where it may be life or death for the baby and the mother, just makes a lot of sense of why they may have started using plant medicines in the first place. Didn't have sonograms, didn't have emergency C-sections, but what they did have was a strong connection to these plants. But there are interesting pharmacology reports that have come out that may lend some credibility to the neurobiological effects of why they were administering psychoactive plants during pregnancy, even during birth or after, to promote the release of milk production. So mescaline, which is the active compound within peyote and San Pedro cacti, this stimulates the release of prolactin by fourfold, and prolactin is the hormone that's responsible for milk production and milk release. It's also been found that mescaline can stimulate serotonin type 2A receptors, and this is true as well for other classic psychedelics, and it can cause vasoconstriction of the uterus. This makes sense if someone may be using these compounds during birth to help with contractions, and it was actually shown in a rat model that higher amounts of mescaline induced uterine contractions. So this may be what indigenous tribes observed from using these plants. But it also makes us think more too about some of the conditions with PMS or PMDD, where stimulating serotonin receptors in the uterus could potentially have effects on the symptoms. Ayahuasca traditions are also known to use this plant mixture during certain times during the pregnancy, birth, and lactation period. And this includes a Santo Daime, which is a mestizo tradition that some of you may be familiar with. It's more based on a religious practice with ayahuasca. And they can sometimes take ayahuasca either in a symbolic amount, but it's been part of their choice as a woman in their body to have the right to drink ayahuasca during pregnancy and birth. And in 2010, the Brazilian government actually did legislation to say that guarantee that women could continue to use ayahuasca and exercise their parental rights, or even their children to have small amounts of ayahuasca if they thought it was fit to do so. So this is a really interesting topic and conversation, but one thing to keep in mind is probably a lot of cases, dosing is small, maybe not continuous. They also use ayahuasca as part of their birth rituals, where they may put a drop of ayahuasca on the baby's forehead, a drop on the tongue, and a drop on the heart. Again, a symbolic way of connecting with spirit of every part of the life cycle from birth to death, where ayahuasca is central to their religion and medicinal practices. And there I have a report in the document I gave you where there's a review of potential adverse effects of looking at indigenous tribes. And while there hasn't been any reports that I'm aware of birth defects or neurodevelopment abnormalities from the use of indigenous people with plant medicines, we still need to be very cautious about how we interpret this information and know that it hasn't been tested in controlled clinical trials. So we can't say that, yes, this is safe. And one thing we can start to look at is psychedelics are small molecules. They easily pass between the brain-blood barrier. They're lipid soluble. And for these reasons, it's very likely that they cross the placental barrier during pregnancy and would reach the fetus. Serotonin is a very important neurotransmitter with specific effects on timing, so first trimester, second, third. And we just don't know what the effect would be of psychedelic compounds being ingested by the mother. There's a lack of data to know what these risks might be. There are, however, studies that show that high-dose recreational ecstasy users, oftentimes this is also polydrug using mothers that were studied, as well as with stimulants, can have a negative effect on the developing fetus and cause neurodevelopmental problems for the child after birth. There's also a study in the document I provided about ayahuasca that was tested in rodents at an intermediate and higher dose. It was administered every day, I think for 20 days within gestation. There were some negative side effects determined for the mother and the fetus. So we really need to have more information, more studies. And if you're curious about how the FDA goes about this, there's a link in the document to the FDA guidance on reproductive and developmental toxicity studies and how they start to approach this to have a better understanding of what the risks might be. As far as breast milk goes, again, because they're small molecules and lipid soluble, most psychedelic compounds are thought to pass into the breast milk. This hasn't been studied yet, but you would want to understand, okay, if it's in there, how long is it going to stay and how long are the metabolites going to stay? Because MDMA, for example, major metabolite is MDA, which can also have psychoactive properties. So, for example, psilocybin has a half-life of 3 hours. It's expected that it would probably wash out of breast milk within 48 hours and because it's undetectable in a mother's urine after 24 hours of consumption. It's this type of information that you would want to really fine tune if these substances made it to the market and became prescription medications for mothers that may be using them for postpartum depression or for other reasons. One example of this type of study that has been done, it was only in 4 women, which is really small, I think, to really conclude and make generalizations to other doses, but 2 IM doses, so intramuscular injections of ketamine into mothers who were breastfeeding. They then measured the breast milk and found insignificant amounts of ketamine and its metabolites after 12 hours. So here the idea is that a mother could potentially just not breastfeed for 12 hours, have a supply on hand from before the ketamine infusion or injection. Again, we don't know about oral administration of ketamine or IV, and this is important route of administration for pharmacokinetics. In only 4 women, people metabolize things in different ways. So I would like to see more data and more information of these types of studies. Another piece of information to think about is there's a study by Anderson et al. That looked at medications, so not psychedelics, just medications that mothers are prescribed. And they found that in infants that were under 2 months of age, there was a rate of 78% of medication-related adverse events. But this frequency dropped to 4% once the infant was 6 months old. So there may be better tolerance as the infant ages, and that would also play into thinking about any type of treatments or interventions. So we really want to understand when, what substances, dosage, exposure, infant age, and physical and psychological risks to the mother and child. I want to point out the psychological risk here, because if we're talking about giving a full dose psychedelic experience to a mother, the time to integrate that experience, and we know that psychedelics can cause some people to become unstabilized for some period of time. The risk to a child if the mother can't be attentive during early stages of newborn, when a newborn is present, it's this type of careful approach we would want to know a lot about before we would say that this is what the risks are and what's the likelihood of something like that to happen, and how best to support both mother and child if this was a treatment strategy. And I would say this is very relevant too for ketamine, which has been tested in a few studies. And, I know it's being used off-label for depression, including postpartum depression. So the studies that have been published, there are 4 that I was able to find. And these looked at women that were having cesarean sections, and the results were mixed. Some studies found that ketamine could help with depression 2 and 4 weeks after delivery. They were given the ketamine or a placebo while they were undergoing the cesarean section. Just an interesting paradigm there. And, the study that found no results measured depression levels at 3 days and then 6 weeks after delivery. The dose was different between the 2 studies, so perhaps that was the reason why the studies found different effects. But nonetheless, it would be important to further evaluate what the appropriate dose, the timing of the administration, and just how long the antidepressant effects would be expected to last. Okay, let's talk about microdosing now. This is when someone takes a small dose, usually it's 5 to 10% of what we would think of a full dose being. Idea is that you don't have the sparkly, you don't have visual hallucinations. It's subperceptual, or just maybe you feel a higher mood, you feel a little better. but it's not the full-blown psychedelic experience. And so Dr. James Fadiman, who is credited with popularizing this term microdosing in his book, Psychedelic Explorer's Guide, that was published in 2011, he went on to do a survey with some colleagues. And one of the most interesting things he found, and he actually told me about this early on in 2015, was the reports that they received from women on these surveys, talking about how microdosing helped them with their perimenopause symptoms, reducing hot flashes, modulating their body temperature better, improving their mood. They also felt like it helped to alleviate premenstrual symptoms, including headaches, pain, fatigue, mood swings. Some people talked about how their periods became more regular. And it's also been pretty common knowledge that higher doses can either shorten or lengthen the menstrual cycle. Several people talk about maybe they've been in ayahuasca circles and they get their periods early. We think back to what we were talking about with the effect of classical psychedelics on the uterus, that may be why, but we really don't know. So here are some anecdotal reports that were pulled from the survey to give you a better idea of how women described microdosing and what it did for them. Someone said, my period was always very severe in terms of pain. The pain even went through my entire stomach, back and legs. Sometimes if I didn't take pain relief medications, it was vomiting because my stomach didn't pull the pain. I started microdosing, and from that moment on, I have almost no pain during and before my period. Another person said, I am microdosing for perimenopause, and it saved me. Stopped my night sweats, reduced my hot flashes, and I'm back to sleeping again. Seriously, a miracle I want to share with everyone. I would love to be part of a study on the subject. I just can't find one. We still don't have any studies on this. The next person said, this may sound bad, but not completely crazy. The roller coaster of emotions that have no explanation other than hormones are lessened, and the existential dread is gone as long as I dose consistently. So this is all, kind of lining up with some ideas. It might be pointing us into some directions of what to look at, potential applications for these lower dose administrations. And why might these lower dose administrations, or potentially full doses as well, work for women's health issues? One reason is the modulation of hormones. So either directly impacting how the circulation of hormones in major endocrine systems of the body. It may also be that the neurotransmitter release triggered by psychedelic substances have a tuning effect on the hormone levels that we experience in our body. It may also have a tuning effect on how much estrogen withdrawal during our normal cycle, how much that affects us. It may be able to just reduce our psychological noticing of it, or perhaps it is a physiological effect, and that's why people reported what we saw in the last slides. Also, I think I forgot to mention, but estrogen has an antidepressant and anxiolytic effect on its own. Estrogen is also known to induce neuroplasticity, and it can be anti-inflammatory. Women are more prone to inflammatory states, and it's probably this interaction with estrogen. So some conditions like PMS and PMDD, fibromyalgia, a lot of this relates to inflammation, it's thought. So psychedelics have also been shown in non-human models to increase neuroplasticity and to have anti-inflammatory effects. So my mind goes to, is it possible that we can use psychedelics to help facilitate what estrogen is already doing in the body? Or perhaps it could act to fill in whenever estrogen is not producing these effects. And this may also lead into the symptomatology of when estrogen drops during certain times of the cycle or the life continuum. When I was preparing for this talk, I had posted it on LinkedIn, and someone wanted to know about birth control pills, as well as some other conditions like polycystic ovarian syndrome, and as well as endometriosis, which are very painful and related to hormone regulation as well. And there's just not enough information to go into too much depth in this talk about these different conditions. But I would say that all of this potentially is a target for more research because of the regulation of hormone and the intersections of pain, stress, and the symptoms we've already been talking about. The idea too about birth control pills, I think we would want to understand more about what these effects are on the actual experiences that people have during psychedelics. But all this is to say about the neurobiological hypotheses is that we just really don't know. And because there are so many individual variations between women and then also across the cycle or the place you are in life, it would be useful for psychedelics to take in all psychedelic treatments to take all of this into account. With the advancements in technology, we can start to see where this might all be going, where we could have large amounts of data related to our biomarkers, and potentially artificial intelligence could help us piece it all together and come up with a really individualized, targeted approach for a specific health issue or symptom. For example, if we're thinking about treating PMS or PMDD, we would want to know, when do these symptoms show up? When are they the worst? What part of the menstrual cycle? We could have a readout on where you are with these circulating hormones, as well as other life factors that could be collected with your phone or wearable device, such as what you've been eating, how well you've been sleeping, what's your level of stress. Is it possible that we could come up with specific doses or specific timing to administer a psychedelic or psychedelic-like compound to help with symptoms? I'm hopeful that this could be an approach we see in the future. The other phase of menopause, this too, there's a lot of different regulation of body temperature, your cardiovascular function, as well as the release of melatonin through circadian rhythms that can be influenced as well by this in this period of time, change of life. So perhaps there would be some specific interventions that could come up and more personalized based on the substance, the dose, and timing of where someone is. Okay, so psychedelic therapy for mental health. There's a lot of different indications being studied. There is one group, the GH Research Company, that is investigating 5-MeO-DMT for postpartum depression. This is a very potent and fast-acting substance, and perhaps because it's fast-acting, the experience may only last for about 15 minutes. With some time to really come back into the body. So perhaps this is the short timing is interesting pharmaceutical development for mothers for the reasons we already spoke about. But there are lots of different conditions here. Women are affected more. Ideas that they're adjuncts to psychotherapy, helping to catalyze that experience of going deeper internally and trying to process emotions, traumatic memories, looking at different aspects of your life. Maybe it's facing that end of life experience, whatever it may be. There's a lot of different applications for psychedelics, including lots of different substances. And as we talked about earlier at the different pharmacologies, we would want to really get into what type of substances, doses, and therapy approaches are most effective for women. And is there variation depending on if you administer these treatments at different points in the menstrual cycle? They're not going to be cheap if you seek this out from a doctor, if they do reach approval from the FDA, or even if you are just participating in a ceremony or something like that. It would be nice to know if there are specific side effects or potential points in that time where you're likely to have a better and more productive experience for the outcomes that you're hoping for. And to this point, we know that there are sex differences in our drug responses. And this has mostly been reported through drugs of abuse like cocaine. So it's been shown that when estrogen levels are high, women report a greater high from cocaine. They like it more during this phase when estrogen is higher. During the luteal phase, when the estrogen is declining, the response to cocaine is reduced. It's also shown that PMDD, there's an increase in the SERT binding across the menstrual cycle. So this is that transporter that's bringing serotonin back into the neuron, also the target of MDMA. They respond, some people, not everyone, respond pretty quickly to SSRIs. And it's thought that women in general are more responsive to SSRIs, indicating that serotonin may reduce negative mood effects of hormone fluctuations. So this is a sex difference between how women respond to different medications. For psychedelics, we know that it's been reported that MDMA effects, including stimulation and the rate of anxiety, is higher in women compared to men. And women also show more elevation of heart rate and blood pressure to MDMA in this report here. So the FDA does require for pharmaceutical development that you do analyses to compare men and women so that you know if there's a greater risk of side effects. However, a lot of the studies being conducted right now, including MAPS phase 3 trial for MDMA, includes only 200 administrations, and this is half placebo, half MDMA, and then probably roughly half men and half women. So it's really not that many people to start to narrow down where are the potential risks or side effects that could be more prominent for women. So I would love to see more research that is specifically focused on these factors, which gets to our last slides here about the future direction of where do we need to go in this field of psychedelic medicine, and how can we best facilitate these treatments for women specifically. I see this as being an interaction of these different factors, the substance and dose, looking at different receptor targets in the body and the brain, looking at the desired effects versus the side effects. Can we make adjustments based on age, where someone is in their cycle or the life cycle? The environmental factors we know play a big role, and I highly recommend that before any drug or intervention is given is the lifestyle modifications that can sometimes be tricky to implement, and perhaps psychedelics can help us have more motivation and push us in that direction to have better diet, exercise, and healthy relationships. But nonetheless, we can take into account stress, the sex-specific risk. What about epigenetic factors? Didn't talk much about genes, but this plays a big role in all of this. Socioeconomic factors as well as diet. We talked quite a lot about the neurobiological and psychological factors that come up. So again, can we get better at monitoring and looking at how psychedelic substances are going to impact the menstrual cycle, hormone levels, the gut biome we know very little about, but seems like a plausible place to look. And how's this going to be regulating our emotions, cognitions, and biomarkers? And so the idea being here that across these different transition points, it's biological and it's psychological. So how can we potentially apply these treatments just to make us have better quality of life, less symptoms, and better moods overall?